Okay, I want to talk for a few minutes about System S obturation. The letter S stands for Stropko. A lot of people may not realize that, but John Stropko, kind of tongue-in-cheek, started the name System S. He used to teach this technique in his office in Arizona, and I was fortunate to go to an endo course there, and part of the course was this System S obturation, coneless obturation. Some people call it squirt obturation, but you're obturating teeth with no cones. What I don't want to do is on this video is get into a philosophical discussion about whether or not this is the best way to obturate teeth, because I don't have any feelings on that. This is my preferred way to obturate teeth. Since 2006, when I learned this technique, I've obturated probably 99.9% of the teeth I've treated with this technique. But that doesn't mean it's the right way to go for you or in general. So having said all that, let's discuss the technique a little bit. These are a couple teeth that I filled in the last couple of days. And yes, this is a little bit of overfill of material here and here. So if you're not comfortable with that, you don't need to watch anymore, because if you use this technique, you're going to have splashes of sealer. Let me go to slides, just the nuts and bolts of the technique. These are actually John Stropko's slides. You can find these the same place I found them, on Rob Kaufman's website. He's an endodontist in Canada. He's got this amazing resource at endoexperience.com. That's where you can find this. You can just Google it. So this slide says Kerr Pulp Canal Sealer. I actually do still use Kerr Pulp Canal Sealer, but I don't use EWT. I use regular set. You can use other sealers with this technique. It's not critical. In my hands, I like this one the best. You want to make sure the canal is dry and patent, if at all possible. You want to apply the sealer with a paper point to full length. Stropko used to talk about the appearance of the paper point as splotchy. So you don't want a lot of excess sealer. You need to put in enough sealer that you've coated the walls, but then you're actually going to be removing sealer with a couple more paper points until you kind of see a splotchy appearance. It's hard to appreciate on this slide, but you'll kind of know it when you see it. I still like to use the Obtura too. You can also use a device like this. This one's from B&L. It's cordless. Also has a mechanical ratcheting mechanism. It's not electric like some of the newer units. I like the reliability of a mechanical ratchet. This is the good old Obtura that you see on the slide. I still use this a lot because it's just so reliable, has a great feel to it, and it's pennies to operate. I still use these pellets, Schwed regular flow pellets. Other pellets work fine too. I still use 200 degrees, the temperature here. I like 200 degrees, and I like a 20 gauge needle. The reason being, Stropko stressed this, the reason being, if you're using a fatter needle, this is the fattest one they have, and you're using the high temperature, the material flows better, because the minute that material gets to the end of the needle, it's no longer 200 degrees, not even close. Once it starts to move down the canal, it's a giant heat sink. The tooth is a giant heat sink, and it loses temperature rapidly. So if you're using lower temperatures and smaller needle tips, it becomes more difficult to get material to the apex. The most common mistake when you start doing this technique, the most common mistake you will have is not overfill, it's underfill. You're not going to get the material to the apex. So just keep that in mind. The fatter needles and the higher temperature helps with that error. But you can certainly do the technique with 23 gauge needles, and you can certainly do the technique with lower temperature gutta percha. Again, he's talking about the feeling the pushback. Make sure your Obtura needle, or whatever needle you're using, make sure that needle doesn't bind in the canal. You want it to be down in the canal but not binding, so that as you inject and the gutta percha comes up, you feel a little pushback on the needle. If your needle is binding in there, the canal becomes an extension of the needle. That's why this material flows to the apex. So if you're bound up and you're patent, and you can't feel the pushback because your needle is actually stuck in the canal, just like with hypochlorite, it's going to go out the apex. You can't have this needle binding. So that's something to keep in mind. Here he's talking about tips for packing the gutta percha. You want to pre-measure your pluggers, although I got to tell you, I really don't pre-measure because I'm never taking my plugger this deep. I'm probably not taking my plugger too much down the root at all. It kind of depends on the tooth and depends on the situation. He mentions here these Dovgan pluggers from Joe Dovgan, the late great Joe Dovgan. I was fortunate enough. Also, Joe was there. Dr. Dovgan was there when Stropko was teaching this course, and those are just a couple amazing guys who really helped me at that time to learn this technique. So yeah, don't bounce off the gutta percha. Don't just kind of push and pull back. And I also don't like to pierce the gutta percha. I think it says right here, keep a wad of gutta percha ahead. I've also heard the phrase shepherd the gutta percha down the canal. That speaks to, you know, if you push too hard, you just push your plugger right through the gutta percha and it comes up all around the plugger, and you pull the plugger out and you pull all the gutta percha out. So you just want to kind of, you know, keep the gutta percha ahead of your plugger. Like I said, I'm never taking the plugger this deep, and I'm certainly never taking my plugger down to where it binds. So be careful, don't bind the plugger for the same reason you don't bind your needle. You'll get a massive overfill. And here, he's just talking about the same thing. So enough of that, enough of those slides. Let's see what I've got here. Let me go to this is a Dovgan plugger. You can see here we call this one the blue black. It's a 6080. This is nickel titanium. I use the blue quite a bit, although lately shapes have gotten more conservative. I'm using the white Dovgan quite a bit more than the blue. Another thing I like about the white plugger, this is a 45, I believe, yeah, 3545 Dovgan condenser. I like this 45 because I operate under the microscope and I don't do anything blind, so I can see as I'm pushing, I can see gutta percha coming up around the tip of the plugger, so I know how deep I'm going, and I know that there's space. I'm not binding against the dentinal wall, so I know there's space for back pressure, and I'm not going to force a bunch of material out the foramen. Let's see if I can get out of here. A little more about the technique. Alright, let me run through these images, and as these images come up, we'll just talk about what it is that I thought was important to show. That's just a recent case. Let's go here. Here's a case. Some people are concerned about obturating near the canal. In this case, it's necrotic. When a case is necrotic, you don't have the resistance of the bone and the ligament in this area, so it's easier to get an overfill. One way to sort of obviate that is to do a two-step procedure. Let me see if I can open that. There we go. So you can do this in 2 visits, and that allows for some healing here, and you're less likely to get an overflow. This looks like it's just a little splash of sealer. I'm real comfortable with that in this case. I got no problem with this as an overflow. If I haven't over-instrumented, if I haven't poked a big, heavy, stiff piece of metal or nickel titanium or stainless steel through here and into the canal, then I'm not worried that all of a sudden gutta percha is going to bust through there and cause a problem. But obviously, if you're not comfortable with that, don't use the technique in those areas. Okay, here's a case of an upper molar. It's good to start, if you're going to start messing around with this technique, it's good to start on maxillary teeth, especially premolars and maybe first molars. Especially if the roots aren't into the sinus, you got nice resistance, nice bone. Anatomically, this is a very safe area. If you get an overfill, you don't have to freak out. So that's a good thing to do, is start on maxillary premolars. Let me see if I've lost my place. Yeah, I have a little bit here. Sorry, guys. So this, oh, I know what I wanted to show you. So here's a case. The MB1 and the MB2 are confluent. So this is a common problem when you're injecting, when you're using this technique. You'll inject, it'll flow down one canal, and then it'll be easier for the material to flow back up the other canal instead of to the foramen. So in this case, you can use a PacMac, if you guys know what these are. Here's one here. I should have got one on the website. This is a PacMac. It looks like a nickel titanium file. It's sort of like a reverse threaded headstrom. There's a way to use those and down pack. The other way that I use almost just as often is I will unpack one of these canals. So I know that it's filled to the point of confluence, so I don't need to unpack the MB2. I'll usually unpack the MB. This will happen on lower molars as well. When you've got two distals or even two mesials that are confluent, this can happen. So unpack the one that's easiest to get to. In this case, usually the MB, really easy to take a file, my last file used, and just gently run it back there. Don't create any ledges and just pull the gutta percha out. Reapply the sealer and go at it again. Let's see if I've got it here. So here it is, completed. Now we've got the nice little signature System S puffs. Let's see what else I got to show you. If you're started doing these very conservative shapes, and you're a big proponent of these conservative shapes, this technique will work just as well. This material flows really well down narrow shapes as long as there's taper. You don't have to take the needle further than this. You can take your Obtura needle just to here. You don't have to have that Obtura needle way down the canal. In fact, it's probably better if you don't. But a 20 gauge needle will still get into the orifice of the canal. If I've prepared it so narrowly that the 20 gauge needle will not fit in the orifice of the canal, then I need to use a 23 gauge. And there are times when I do use a 23 gauge needle, and I know some people that have used this technique for years and have gone to 23 gauge needle because their preps are getting so much more conservative. Sorry about that. Let me see if I can find the right one here. Here's a recent retreat. This is the pre-op. Again, see this long-standing lesion? I know a lot of people think this tooth is cracked. They're calling this a J-shaped lesion. I didn't see any evidence of crack. So we did an exploratory, opened it up, saw no sign of a crack. Calcium hydroxide came back in a month, no probings, and obturated. So here, again, pretty good overfill of sealer here. Even though it had been a month or so, we're getting some resolution of the lesion, or this stuff would have splashed way down into here. But I'll expect on recall to see this healed up. Even gutta percha will resorb. This may just be sealer, but even if it's got some gutta percha in it, it will resorb if you want to give it 10 years or more. That was always sort of the joke there. Let me see what else I have here. Oh, here's a case where I used the PacMac. Let me see if I can find it. So these canals are very large. This must have been a young patient. These canals are pretty large. So on the distal, again, injected, it went down one side, found the confluence, and started coming back up the other side. So the material didn't get to the foramen. In this case, rather than unpack one of the canals, I just went with the PacMac. Either way works fine. Not a big hassle to do, but that keeps some people from doing the technique. Again, this is going to be the more common error an injection that comes up short. Overfills are not going to be the more common error. This is going to be the more common error, especially when you start. And so where is the post-op on that? Let me see if this is it. So there's the post-op. Same tooth. You can see these are pretty good sized canals. And look at this irregularity down here where it actually, I see this fairly often, where there's actually a discontinuity of taper in these distal canals. There's sort of an area of widening at the foramen, or in the apical 2 or 3 millimeters. And if you're not using a warm technique, you're not going to obturate this area very well. You're going to see your cone there, but unless you're getting heat down here and really doing a thorough cone pack technique, you're not going to get a good result. But look at this tooth that's not treated. You can see the size of these canals. So even though these preps look big, that's kind of what I had to work with. I wanted to show you a screw up because they happen. Let me see if this is it. No, this is that other post-op I was showing you. Again, little bits of sealer finding their way out. Maybe a little bit of gutta percha here finding its way out. If this makes you uncomfortable, that's not the technique for you. But you will find, just while this is sitting here, you will find that these wider canals can actually be more difficult to obturate than narrow canals. The needle and the canal kind of become one continuous taper, and so the material will flow really well. On these wide canals, sometimes the material doesn't flow as well. Now it did here, but real fat canals can sometimes be a hassle. What I really don't like sometimes is like an upper cuspid with a big fat canal. Although anymore I'm using a smaller plugger and making sure I'm just filling the apical portion, take it down to where I've got a good fit with the needle and fill that apical portion, and then do a backfill on a real fat tooth like a cuspid or an upper central, something like that. But real long teeth are not a problem. Length is not a problem. I'd rather have a 32, sometimes I'd rather obturate like a 32 millimeter narrow cuspid than a big fat 18 millimeter distal figure 8 shape on a lower molar. That can be a little bit trickier because the material just kind of flows down one side and back up the other. You don't have that good continuous taper. Okay. Oh, I know there's a screw up I wanted to show you because I had one recently. Thank goodness I get them very rarely, but I had a lovely one. I would say not even once a year I'll get a real screw up. Now Stropko showed several of these. Here it is. Stropko showed several of these with long-term recalls, and he had overfills not just like this, but big time curly Q, huge overfills. And he would show the bone healing around these, and in fact sometimes over time this will kind of drift off and begin to resorb if you have a long enough recall. But if this kind of thing scares you, this may not be the technique for you. This happened, this was probably a combination of errors. Probably didn't realize the size of my foramen, probably didn't gauge it very well, probably didn't create enough taper right in here. And probably didn't leave this tooth long enough in calcium hydroxide to get some good resistance in the bone, some healing in the bone. And in fact, in speaking with the patient, she kind of had a flare-up between visits, not bad enough to give us a call, but she did report that this tooth kind of bothered her for a week or so. It kind of swelled up a little bit on the gum tissue and before becoming asymptomatic. So maybe a little more time in calcium hydroxide would prevent this. But this will happen once in a while, and if that scares you, like I said, this is not the technique for you. Thankfully, I don't know the last time I had one like this, so maybe 1 in 1,000, maybe even more rare than that. This is by far the more rare error. Usually you'll fail to get the material all the way down. So anyway, want to let you see that ugly one. Stropko used to have a really hilarious one that had a big question mark, and he used to jokingly refer to those as bone magnets. So anyway, back to the beginning. That's System S. If you got questions, email me. If not, enjoy. It's a fun thing to do. It's a fun way to obturate teeth. Stropko told me just start doing it and don't look back. If this is what you want to do, if you're comfortable with it from a philosophical standpoint, from an anatomic standpoint, if you've made a decision to learn this technique, just go at it. Just all the way. Start doing it and don't look back. Get up, climb up that learning curve. I've taught other people to do this and they just have fun with it. And you know, having fun is important when you're working. It keeps you mentally in the game. So there's nothing wrong with doing something for the sake of fun, if we also know that we get good long-term results, and we certainly do with this technique. There's several of us been doing it for many years. There's other versions of it. This is Stropko's version. That's the way I learned, and hopefully I gave you some good information here. Thanks for listening.